32-year-old man has 3 days of painful blurred vision in both eyes, headache and fatigue. He is sexually active and was treated with epididymolysis 2 weeks ago with doxycycline and ceftriaxone. He experienced a previous episode of painful mucocutaneous oral ulcers managed with colchicine 1 month ago. Figure 5 shows the examination of the left eye, and which is the most appropriate initial management. A. Carbonic anhydrase inhibitor. B. Corticosteroid. C. Fluoroquinolone. D. Non-steroidal anti-inflammatory drug. Or E. Nucleoside analog antiviral. The correct answer for question 2 is B. Corticosteroid. We can see in figure 5 hypopyon, which is characterized by a collection of white blood cells within the anterior chamber. It is a characteristic finding for anterior uveitis. Anterior uveitis refers to the inflammation of the anterior portion of the uvea. Common risk factors include systemic autoimmune disease such as seronegative spondyloarthropathy, Behçet's disease, sarcoidosis, Sjögren's disease, or systemic lupus erythematosus. Infective causes include herpes virus, cytomegalovirus, or toxoplasmosis. The classical clinical presentation of patients presenting with anterior uveitis include an acute, painful ocular discomfort, photophobia, ciliary flush, hypopyon, an irregular constricted pupil, lacrimation, and synechiae. In patients with suspected anterior uveitis, an urgent ophthalmological review is typically required within 48 hours. Patients typically undergo a slit lamp examination, revealing leukocytes in the anterior chamber of the eye. But when exactly do we refer patients to ophthalmology? Well, commonly used mnemonic is RSVP. R for redness, S for sensitivity to light, for example in photophobia, V for visual change, when a patient presents with a diminished visual acuity, blurred or doubled vision, or P, pain on ocular movements. Now, in the context of the clinical vignette, we had a patient with a history of recurrent genital and oral ulcers. In the context of anterior uveitis, this is in keeping with a picture of Behçet's disease, in which patients are typically positive for HLA-B51. We can see this being demonstrated in figures 6a and 6b. Regarding the management of anterior uveitis, an urgent ophthalmological referral is indicated, alongside immediate topical prednisolone and cyclopentolate to mitigate inflammation and alleviate ciliary spasms respectively. Cyclopentolate is a mydriatic drop which dilates the pupil to relieve the pain in photophobia. Regarding the chronic long-term management, it is important to address the underlying etiology which may be predisposing patients to developing anterior uveitis. As already discussed in a previous slide, the most common causes of anterior uveitis are chronic autoimmune diseases. As such, these can be managed with the following therapies. For example, immunosuppressive drugs such as methotrexate or mycophenolate, or TNF inhibitors such as adalimumab. Alternatively, in refractory cases of anterior uveitis, laser phototherapy, cryotherapy or vitrectomy may be indicated. Furthermore, it is important to consider following up these patients who may be on corticosteroid therapy or on immunosuppressants to check for intraocular pressure to assess for glaucoma, as well as the full blood count to check for neutropenia.